Welcome to this Wise Words academic seminar hosted by the Contemplative Study Center at the University of Melbourne. I'm Nicholas Van Dam, the director of the center. We respectfully acknowledge the traditional owners of the unceded land in which we work, learn, and live, the Wurundjeri, Woiwurrung, and Bunurong peoples. We pay respect to elders past, present, and future, and to any Indigenous peoples present here today. Today, we're joined by Dr. Anya Daly, Senior Lecturer in Philosophy and Ethics at the University of Tasmania. In today's presentation, Anya will suggest that the pattern theory of self can be a useful tool to make better sense of the lived experience of those suffering mental disorders and to enhance self-understanding, such as in the contemplative traditions. If you have any questions, please post them in the Q&A at any stage, and Anya will address as many of those questions as she can towards the end of the session. Thank you all for joining us, and welcome, Anya.
Right. Thanks so much, Nicholas. And thank you also to Kathleen and T for setting this up, and the Contemplative Study Centre for hosting the seminar. So thanks also to the audience who I cannot see. Thank you for your interest in this topic. As this is a work in progress presentation, I'm hoping to receive some useful comments and criticisms from you in the Q&A. So please don't be shy, and I'm sure Nicholas will be able to copy them and paste them into some document to send me if we don't have time to address everything. Okay, so we're going to be looking today at the examination of self-patterns. So this is a project that Sean and I have been working on for a number of years, and we have two co-authored papers concerning this topic already published. And recently, the psychiatrist Rosa Rutanano, who's based between University of Birmingham and University of Melbourne, has joined the team and is crucially offering both a clinical perspective and her research into epistemic and hermeneutic injustice in the domain of mental health. So this is the overview of what I'm going to cover. Excuse me for inserting in that French word. You know, I still like to see the French from time to time. So problématique, setting up the problem. So the problem that our project is seeking to address, along with relevant historical and theoretical context, will be the first thing that I will address, because I think it's important that we situate the topic, because I'm sure that there are some people there who may be familiar with some of the material, but maybe not familiar with all of it. And I also want to motivate the topic. Why is this an important topic? So we're going to do that, and this will be necessarily brief. And so if anyone is interested in investigating these aspects further, there are papers that include extensive reference lists that Sean and I have written. So, you know, feel free to pursue that as well. So secondly, what the phenomenological psychopathology program offers is something that we're going to be focusing on, and also how our contribution to this is different, and how this differs particularly from the DSM and ICD. So we're going to be offering an alternative phenomenological interview based on Sean's elucidation of what is called the pattern theory of self. So we're going to also look at how the pattern theory of self can be transposed into a workable and arguably more efficacious protocol for diagnosis, therapeutic interventions, and research. And we've called this the examination of self patterns, ESP. You might think, oh, that's not a suitable topic, but title, but it works very well for us, because a lot of the phenomenological interviews are called examination of self-experience or world experience or time experience. Okay, so most importantly too, for our situation here in the Contemplative Studies Centre, is this protocol will be adaptable to conducting empirical studies in contemplative sciences. So we're hoping that, you know, there may be a bit of take up from that. All right, so the launching place of our project and what motivates our project is the now well-known problem with psychiatric classification, exemplified notably in the DSM and the ICD. And while some of you will be very familiar with this territory, there may be others who will appreciate a quick summary of the key points to provide a bit of context, and also to locate our project historically and thematically. So there have been a number of successive theories, diagnostic methods, and treatments in the history of psychiatry. Excuse me. And with each new approach, there's been the hope that the reconceptualization of madness or lunacy and the employment of novel methods would break through the theoretical confusions and offer pathways to rational clarity and mental health for those suffering anomalous experiences. Nonetheless, despite those initial enthusiasms heralded by each of the new approaches, all have been found to be inadequate to greater and lesser extents. So here I've got a list of some of the key historical and theoretical shifts. Humoral theory, confinement with the madhouses and the asylums, the moral treatments of the 18th and 19th centuries, the medical model, psychoanalysis, behaviorism, psychosurgical interventions, including lobotomy, and now we've got deep brain stimulation. Social constructionist theories of the 60s, that madness arises from living in a repressive society, psychopharmacology, with all the drugs, mother's little helpers, such as Valium and Prozac, to the recent investigations into psychedelics, which is bringing up some interesting results. Psychogenetics, neurobiology, and the hybrid biopsychosocial models. Okay, so all of those. And so today, as Joseph Parnas and Sean Gallagher note, the psychiatric object, which is the traditional way of referring to a patient, which seems really awful in itself, the psychiatric object is typically portrayed as an objective, thing-like entity, unproblematically graspable as it exists in itself, through a behaviorist third-person perspective and as being indicative of a specific and modular physiological dysfunction. Okay, and so the treatments of the mad, and I use that, with scare quotes, in the history of psychiatry on the basis of various theoretical accounts and diagnostic systems, have ranged from the benign and sometimes helpful to the ludicrous. And here I'm reminded of my most favorite fact of hysteria, based on the idea that hysteria was caused by a wandering womb. And so the treatment was to present a really bad smell like a rotten fish or something to the nose, and a posy of sweet-smelling herbs and flowers at the vagina. And this will encourage the vagabond womb to return to where it belongs. And all the problematic symptoms will be resolved and the woman will become sweet-natured and amenable again. Okay, so pretty crazy stuff. And so picking up our thread, so from the benign to the ludicrous to the most brutal. And of course, we can say that, the most horrific procedure, I think, in fairly recent times is lobotomies, and that stands out for its brutality. And to the criminally reprehensible, involuntary incarceration. And we could also add sexual conversion therapy to that grouping. And the politically oppressive, the very categorization of homosexuality as a mental disorder. And the fact that irrationality has been predominantly attributed to women, artists, and dissenters. And this has led to systemic injustices and oppression. And so psychiatry most certainly has a very checkered history. One of the key claims that we argue for is that madness requires rethinking from the bottom up, and that the crisis of legitimacy in psychiatry, due to its checkered history, persists today significantly due to the attempts to medicalize mental health issues by conceiving anomalous experiences as equivalent to diseases susceptible to neat categorizations. So this critique of historical and mainstream psychiatry is not new, and many psychiatrists themselves are highly critical of how the system currently works. There's also the problems with methodology. The problem with any psychiatric interview, however, as commonly understood and as commonly articulated, is the challenge to reliably translate the first-person experience of the patient through a second-person interview protocol to arrive at a third-person objective account, which then lends itself to classification. And so while the return to phenomenological psychopathology and the various iterations of semi-structured interviews have come a long way in addressing some of the deficiencies of the fully structured interviews of the DSM and the ICD checklists, there still remains the end goal of identifying a classification so that the pathways to support and treatment can be facilitated. So criticisms that the fully structured interview, in a sense, corrals the patient's experience into fixed categories as already defined and predetermined by the theoretical framework, are borne out by the persisting difficulties with the DSM and the ICD. And it may be said that the imposition of a structure on the interview obscures or even elides what may be most salient for the interviewee, the patient. So in this way, fixed structures in the interview process become counterproductive to a more accurate and richer understanding of the patient's experience. So what is clear is that unlike medical science, which relies on blood tests, scans, and physical examinations, psychiatry's means and measures are much more uncertain. So we have evidence of this in many ways, but just to name a few, there are significant problems concerning diagnostic accuracy, demarcation problems when there are comorbidities, the well-documented problems of symptom amplification, and complications arising from stigmatization and looping effects. And even neuropsychiatry, which seems to promise so much, still is unable to establish clear correlations between mental states and neural states. And ultimately, neuroscience will never be able to offer understanding of the subjective experience, what it is actually like to have such states, and how these states impact on the patient's life. And so this is where phenomenology becomes essential. The third-person naturalistic explanations of mental illness relying on neurochemistry, neuroimaging, and neurobiology need to be brought into engagement with the first-person phenomenological accounts that can capture the lived experience of those suffering from mental health disorders. The phenomenological psychopathology framework is advancing this important work, and psychiatrists and psychologists practicing within this framework have been able to offer some very insightful breakthroughs. And what they all have in common is the idea that mental disorders are most usefully conceived as disorders of self, and that consideration of the first person perspective, giving due respect to the lived experience of the patient, is key to both understanding and treatment. However, we suggest that some of these remain in the medicalized disease model, and the methodology is still caught in the classification program with symptom checklists. So we're offering an approach that is distinctive in that, firstly, it is not concerned with classifications, and secondly, it involves a participatory analysis. So I'll deal more on that shortly. So, disorders of self. We have proposed a comprehensive theoretical framework that supports the view that mental disorders are disorders of self. And Sean, in fact, has a new book coming out from Oxford this year with the title Self and Its Disorders. So the undergirding theoretical framework of the PTS, the pattern theory of self, and the ESP, the examination of self patterns, is and its application in the therapeutic context. So the theory is the PTS and the application is the ESP. So what is our overall claim? We propose that the ESP phenomenological interview developed on the basis of the PTS will prove efficacious in addressing the inherent complexity of mental health, the protocols of clinical practice, and the requirements of research. Okay, so this sort of seems like, it's a big task. and we're hoping it's going to work. We need a lot more empirical support to really pull this together. So this is where we're hoping to move next, is gathering a lot more studies to support how this program can work. So first of all, let's have a look at the PTS, the pattern theory of self. So this view is consonant with the views in phenomenological psychiatry, and it dates back to the work of Karl Jaspers at the beginning of the 20th century, but also brings phenomenological psychopathology into the 21st century. So this is what we're aiming to show. So what are some of its distinctive features? The PTS is non-reductive account of the self. It's consistent with embodied inactive approaches to cognition. So any of you working in psychology will probably be familiar with that approach. It's certainly very big in philosophy. It takes a pluralist, holistic approach, defining the self as a pattern of dynamically related variables that include cognitive, bodily, affective, social, temporal, and normative factors or processes, and more than just those as well. And importantly, the PTS foregrounds the multidimensionality of the subject, stressing not only the situated embodiment, but also the significance of intersubjective processes in the formation of the self pattern. Importantly, it emphasizes the connectivity and dynamic relations among the diverse aspects. And it offers a way to track not only the origins, complexities, and progression of mental disorders, but also therapeutic transformation of the individual towards a meaningful life with robust self-esteem and positive connections to the community. So this is the prompts that we're making. It will do this. So there are already indications in the current literature that demonstrate the viability of the PTS as a basis for formulating an alternative methodology. So we've got people from neuroscience and even contemplative science and philosophy, of course, who have sort of looked at this. So it's very useful. And interestingly, it can be employed in a number of psychotherapies, and more broadly as a tool for enhanced self-understanding. So there's one study that I was alerted to by one of your colleagues, Chris. It was by Lindell and Britton, 2019 study that drew on the pattern theory of self to interpret the anomalous experience of meditation practitioners. So very interesting to look at. So what we call self, according to the PTS, consists of a complex pattern of elements or processes, none of which on its own is sufficient to any particular self. The self pattern operates as a complex system that emerges from dynamical interactions of the constituent elements. Okay, so I'm hoping that that is going to be visible to everyone. We're not going to go through it all, but that's just to give you an idea. This is the most recent version of this pattern theory. And you'll see there's the reference up the top for Sean's forthcoming book from Oxford. So it's important to emphasize the dynamical nature of the self pattern, such that particular processes are to be considered dynamically interwoven with other processes. This means that any intervention that is aimed at one of the elements will likely lead to modulation in the other elements. So, for example, the basic pre-reflective experiential element, which involves the sense of agency, can be modulated by more complex relational elements such as normative factors that involve culture, race, gender, health, etc., or intersubjective factors that may affect autonomy. And, there's a lot actually in feminist philosophy that demonstrates this or draws on these kinds of ideas. And we've got the now classic paper by, for example, Iris Marion Young, her paper Throwing Like a Girl. If you haven't read it, I highly recommend it. It's beautiful phenomenology, and it's really engaged with social issues of being a woman in society. Or then we've got the work of Harvey Carell, another very interesting phenomenological philosopher, who is looking at the phenomenology of illness. But we get the idea that, you know, one aspect of the pattern can be affected by other aspects. So it's dynamic, it's very dynamic. So I'd also like to point out that the narrative aspect plays a double role in the therapeutic context. Firstly, as one element in the self pattern that reflects all the other parts, it is kind of like a window or a route into the pattern, and as a means of disclosing the pattern through the second person phenomenological interview. Secondly, narrative is a part of the pattern itself, and due to the dynamic nature of the pattern, a change in self-narrative can recursively affect a change in the pattern as a whole. So that's really interesting from a therapeutic point of view. You know, change your story and, you know, you might change your self-pattern. So narrative is a means of retrieving, disclosing, temporally mapping, and connecting all the other aspects. And in the therapeutic context, the narrative is co-constituted by both the therapist and the patient. Okay. So the ESP are minimally structured phenomenological interviews. So the DSM and ICD are fully structured interviews. Some of the phenomenological interviews that are already on offer, like the EASE or the EAWE and TATE, they are semi-structured. So we've got a minimally structured phenomenological interview. It's very, very, minimal, we can say. Okay, so we've proposed that all psychiatric disorders are self-disorders that can be understood and investigated through disruptions in the self-pattern. And these disruptions can be revealed through the co-constituted narrative that is disclosed in a minimally structured phenomenological interview. And this is what the ESP is. So the interviewer is not merely a means of recording the interviewee's experience, but rather plays a dynamic role in how the interview progresses, not so much in terms of the content that is revealed as in facilitating the disclosure and understanding. And so while epistemic responsibility is strongly accorded to the interviewee, nonetheless, the process or protocol we seek to implement recognizes the dialogical and participatory roles of both interviewee and interviewer in articulating an unfolding narrative and also negotiating a way forward. So through the ESP, we aim to provide a mapping and tracking of the patient's experience, which allows for a dynamic unfolding that is distinctively not aimed at a classification as such. Although a classification may be suggested in the constellation or pattern of experiences expressed, we propose that it is possible to maximize the openness of the interview and at the same time retrieve information and insights that are transposable into a reliable qualitative analysis without a fixed classification. Okay, and so this is why we call this self-selecting salience. So the idea of presence is also key to this minimally structured interview protocol. It's key in the pre-interview phase and during the interview itself. And so practices in mindfulness and meditation more generally become essential here. In such practices, presence is facilitated by attending to the breath, the body, and letting go of conceptualizations, including the idea of diagnostic categories. Chris McCaw and I have a paper in the pipeline on the issue of presence in the therapeutic context, and which draws on some of these ideas. So I'm not going to go into the detail of this work here, but I think it's looking quite interesting. It might be a really good paper in the end, once we get there to the end of it. Anyway, so let's move on to the examination of self-patterns. So the interviewer does not necessarily need to have a mastery of all the techniques in meditation. It would be sufficient to have a familiarity with contemplative practices and be sufficiently attuned during the interview to intermittently and skillfully remind the interviewee to bring their attention back to the body and breath. That's if the narrative seems to become unanchored in the present. So this may be achieved by drawing attention to posture, movement, eye gaze, hands, and to breath holding, quickness or shallowness of breath. Importantly, the interviewer must be comfortable with silence, being present without needing to fill up the gaps with talk. The interviews need to be recorded so that both participants are not distracted by writing notes, nor inadvertently imposing interpretations at this stage, which becomes more likely with any attempt, is made to transpose the communications in written form. So the authenticity of the interactions and the salience of what is communicated are facilitated by the establishment of a space of shared presence. Okay, so we've got disclosure of, just wondering when we've gone there. Okay, oops, no, that's too soon. All right, so as has been stressed, the self pattern is dynamic at both the neural level and also extraneural level, so that more the embodied and active and intersubjective elements, evolving and devolving according to the intervention's experience and understanding. And these evolutions and devolutions can be tracked primarily in narratives of the patient, but also the narratives of the clinician, the family, and significant others. So the examination of self patterns thus facilitates not so much a construction of a narrative as the discovery of previously occluded narratives. And these may serve to further illuminate the challenges being faced by the patient. And also contribute to the creation of aspirational narratives pointing in the direction of possible treatment pathways. Okay, so to show how this works, we're going to examine the narratives taken from patients suffering from depression, as initially detailed in our two earlier papers. And I also have added some further aspects to those as well. And make a comparison with the DSM, just so you can get a sense of the value of this different approach. Okay, and these are taken from vignettes, patient narratives, interviews, and various other sources. Okay, so sorry about that. That's a terrible table, but I couldn't get it all up there in one go without that, and it just transposed the table into this red thing. So that's the whole shebang. And you can see there's the first is the elements of the pattern, the second column is the DSM-5, and the third column are what we've extracted from interviews and narratives of patients. So to make that more visible for you, I have selected some, and we're going to look at this particular one here so you can see a comparison. So the DSM-5 acknowledges that on the experiential level, there can be fatigue or loss of energy in depression. But the PTS is bringing up through the extracting from the narratives themselves and interviews, feelings of heaviness, feeling disembodied, hyperembodied, feeling like an automaton, reduced sense of agency, nervousness, helplessness, walking on a tightrope. All of those kinds of experiential things that are a much more richer account than just fatigue or loss of energy. Another one is, with affective processes. So you can see on the left, the DSM-5 has, very sort of basic kind of things, whereas the PTS has drawn out material that is much more rich in its understanding and appreciation of what the experience of the patient is. Another one, intersubjective processes, MIL for the DSM-5. Okay, so these are some of the ones that we've picked up as well. So this is hopefully going to offer what we're calling a rich diagnosis, and that sort of term comes from Joseph Parnas and Sean Gallagher's work in 2015. So a minimally structured phenomenological interview protocol, and we're going to put this into 3 phases. So the first phase here is just the initial encounter, the initial meeting, I suppose. And, one of the aspects of that is that we must have a good context. So, the room should be quiet, simple, physically comfortable, with chairs that support a relaxed sitting posture. Ideally, prior to meeting the interviewee, the interviewer will have set up recording equipment and taken some time to engage in a contemplative practice, which encourages a sense of presence. So throughout the interview, the interviewer should be aiming for open questions and giving affirmatory feedback, like with eye gaze, gestural, and possibly verbal. Whatever is sensed to be suitable and natural. Sometimes it will be appropriate to feedback what the interviewee has said, rephrase it slightly so that they feel heard, and so that they have an opportunity to correct any misunderstandings, add precisions, or extend their narrative. And I'm sure this will be very, very familiar to many people who already work in the space of psychotherapy or psychiatry. Okay, so the initial phase, the phase one, the idea is that I'm going to remind the interviewee of the importance of body and breath awareness and inform them that throughout the interview process, you may draw their attention to their body or breath. And this may be explicit or implicit through the interviewer's body language and breathing. And do this initially slowly and gently, not too heavy-handed. So, we could say, now I want you to turn your attention to the sensation of your feet and feel the weight of your body being supported and your head supported by your neck, shoulders, mouth, jaw relaxed. Bring your attention to your breath and feel this in your belly as it rises and falls. Take a few deep, gentle breaths and then let go. So remind them also that this is a time for themselves. There's no need to think about what they'll do next. And they have the opportunity to just give some time for, a bit of self-care. So this initial phase may be challenging due to the interviewee's agitation or difficulty focusing, but the aim is for the best approximation of a calm focus in the present. So if you've got an interviewee who is extremely agitated or psychotic or something, this may be difficult or may be a challenge and may not be appropriate. So you have to have a certain level of calm for them to take on board the requirements of the interview. And many of you are very familiar with all of this already, I'm sure. So start with a very open question, what brings you here today? And there may be a situation or an issue that is mentioned, and you could ask when it began. Not necessarily, they may just want to talk. And what do you think is the most challenging or difficult or interesting aspect of your experience or life at the moment? And also, what might you like to understand through our discussions today? So that is sort of putting in some kind of future orientation right from the get-go. That could be useful later on. So phase two, and this is the interview according to the self-pattern elements. And I've got some detail around that, but I'm not going to put that on the screen because it would be just overload. So I'm just going to select one of the things here, bodily existence, as an example. So you could ask the question, how do you feel in your body these days? And without any kind of leading, you do not want to lead. So it has to be, very minimal intervention. So this might lead to indications of diminished health with headaches, pain, fatigue, tension, breathing difficulties, loss of taste, hearing, sight, touch, or smell. It might indicate anomalous feelings of diminishing, expanding, missing body parts, or lack of sensation in body parts, feeling heavy, light, thinner, transparent, thick or dense. There could be an overall sense of the body not being their own, of not being visible, of not existing as others exist, of being controlled by others even, alien forces and such. So that's just by way of an example. And all of the aspects of the self pattern are dealt with in a similar kind of way. So conclusion. What are the benefits of this approach? It's not complicated. It's quite simple and straightforward. It doesn't require you to have this absolutely huge document of various sort of checklists to tick off or and indicate whether various items are present or not present. It's minimally structured, allowing the interviewee or the patient to determine the salience of what comes up. So I think that that's really important, and I think that's part of the issues around hermeneutic justice that this particular approach affords. So it does not privilege one element over another. So with some phenomenological accounts which propose the basic pre-reflective experiential element is fundamental, often this is referred to in the literature as the minimal self. And we get that particularly with the work from Parnas and colleagues around schizophrenia. They say that the basic problem of schizophrenia is to do with the minimal self. And then because of that prioritizing the minimal self, then the other elements are regarded as being downstream or contingent. So the ESP, in contrast, recognized that the self already works as a dynamic gestalt, and changes in any one element may modulate other elements. So it's not sort of prioritizing in any one element over another. And it's up to the patient or interviewee to bring to the attention of the interviewer what is relevant at that time. And that will, of course, change. So it takes account of all aspects of the pattern theory of self, recognizing that what is often regarded as purely internal to the subject of experience is meaningfully and formatively connected with the external world. So in this way, historical and political structures are brought into the account, thereby addressing epistemic and hermeneutical forms of injustice in the psychiatric or therapeutic context. So that's sort of keys in nicely with some of the work that was done in the 60s around constructionist theories of psychiatry. It does not rely on a symptom checklist concerned with identifying whether particular symptoms are present or not present, which could support a quantitative analysis. So in this way, the interviewer does not need to probe and control the direction of the interview in order to produce data. And the ESP is thus a novel, phenomenologically informed, and hermeneutically sensitive interview based on the pattern theory of self, which affirms the multidimensionality of selves situated in worlds that are shared and meaningful. Okay, that's it, and I'm sure there'll be some questions, so I'm looking forward to hearing what you've got to say. Thank you.
Thank you so much, Anya. The questions are starting to come in. Would you mind maybe the tech team is already dealing with it in terms of making sure that people can see us. I guess just a practical question for me. One of the reasons that in clinical practice, and my background is I'm trained as a clinical psychologist and I teach students in the clinical psychology program. One of the reasons that we teach and use the current diagnostic system is for purposes of triaging.
Oh, right. Yeah.
In other words, we kind of view it and think of it as a necessary evil. We know it's not accurate and no one really likes it. But we use it as a way of kind of saying, person A coming in has mild anxiety, whereas person B has severe schizophrenia. And, that way, if I don't have a very long time to sit with somebody, between those two individuals, I can say, well, person B needs immediate and acute care, whereas person A perhaps doesn't. So I guess I'm wondering with the system that are you proposing that kind of this system might replace the current way that we do things, or are you suggesting that sort of, it might just work as a complementary or alternative approach?
Well, personally, I'm not sure of the scope of the use of this at the moment, but it certainly would be useful in the interview situation. But I'm not sure of triaging in terms of in a hospital situation. That's really very difficult. And one of the things that the advantages of, having those categories is that it's not only a matter of triage, it's also a matter of ticking a certain box and putting in a code so the patient can have access to medical treatments, medications, therapy, whatever, and also insurance. So there are systematic sort of things there that are controlling that it stay put, and that, as you say, you don't like it, but you put up with it because you need to do it. It's a necessary evil, as you say. And so triage would be like that as well. So I don't know that it would be useful on the spot in a triage situation. It's more for a booked in an interview with a particular person. So
well, a particular question I think that is potentially interesting along the lines of this conversation is, could you imagine that this approach could be used, say, alongside a DSM-based approach?
Possibly. Yeah, I don't know. I sort of want to resist that. I want to resist that as much as possible because there are so many problems there. But, it may evolve to become sort of, initially it's going to have to be, a parallel kind of system alongside the DSM or ICD. But I think as an initial, encounter with someone who's suffering anomalous experience, it's probably a much more humane and useful and offers a richer diagnosis, as we've been saying, than something that is, got it very fixed on the categories and sort of slotting someone into this particular category or that particular category so they can access particular treatments or, government services or whatever. So I think it could be useful.
And another question, which relates to how do you see the theory as having implications for treatment? So a lot of the current treatment models often, are predicated on a particular, something I identified right in the diagnostic process.
Yes.
So
yeah.
they have these symptoms, therefore I give this medication, or they've endorsed these distorted ways of thinking, therefore I need to correct that. So do you see this approach as kind of being linked to a very particular treatment approach?
I think it can be. So, if the patient brings up particular issues that really, are very strongly within, say, the bodily processes aspect of the pattern theory, then of course you can use bodily kinds of therapies to address those issues, and then it may have a flow-on effect to other aspects as well. It's likely to have, or otherwise, if it's an intersubjective, if it's the intersubjective element, then you may do things along a social way that sort of will, interventions that would encourage them to build up their social expertise or their social comforts, and that will have flow-on effects as well in other areas. So it's just a way of tracking, what is happening with this individual at this particular time, and it's moving all the time. It's changing. So whatever you do, it could have an impact. So one of the uses of the pattern theory of self in terms of analyzing some kinds of interventions, say, for example, like deep brain stimulation, has been very interesting. So what the researchers or the medical clinicians using deep brain stimulation coming up with saying, oh, we've got all these positive kinds of outcomes from it. And we're not discounting that at all, but nonetheless, there's a lot missing. They're missing certain key aspects that would be brought up if they had used, say, like the ESP to sort of interrogate the experience of the person. So it's got a lot of uses, I think, that sort of identifies the gaps, basically, in a lot of the mainstream approaches.
Have you explored kind of how, because you're talking quite a bit about the brain-based and sort of the biological psychiatric kind of modality, I guess, and you've talked a bit about certain aspects of psychotherapy, but have you looked at kind of like functional analysis or, or schema therapy? Like, because there's particular approaches that that we teach in clinical psychology, as an example, that strike me as quite similar to what you're describing, where the goal is to identify whether the person's kind of conceptualization of themselves and their belief system is distorted. And the kind of the way in which you do the assessment then again pairs quite nicely with the treatment that you employ, right?
Okay. Yeah. No, I haven't actually looked at either of those. So I'll make a note of that. Was it schema therapy?
Yeah, schema therapy is one that focuses kind of on broad world conceptualizations and kind of self-identity. You know, and then certainly, I guess, within the more cognitive behavioral framework, you know, a very popular important thing that we teach our students is case conceptualization, which is kind of, you know, what's driving the problem behavior. And then there's a behavioral a technique from behaviorism that's called functional analysis, which is essentially, you know, when a person is exhibiting a particular behavior, so say a maladaptive behavior of, you know, say drinking too much or something, that there must be a reason that they're exhibiting that behavior, and you're trying to identify with them what is driving that behavior. So it does seem like those kinds of models are more analogous to what you're suggesting.
Yeah, I think so. Yeah, that'd certainly be in tune with that approach. Yeah.
An interesting question. So Chris has a comment here that, you know, suggesting that the disorders of self may be problematic. And Chris, I'd encourage you, if you're out there, to kind of maybe tell us why you think that is. But I guess, do you have thoughts about do you think there is an issue with sort of talking about these things as disorders of self? And do you see kind of another way of approaching that might be more dynamic, or allow sort of some kind of spectrum or recognition of, you know, different self patterns? Or do you think are you arguing that that's at the core of what's going on here?
Yeah, no, I think, you know, that's an okay thing to say, actually, that disorders is fine, because the disorders are causing suffering to the person. It's not, you can't sort of dress it up in a nice term and give it a euphemism or something like that just to make it sort of sound acceptable. Though I do understand where Chris is coming from, that he wants to positively frame it as a, you know, as a way forward, you know, giving, you know, more sort of positive direction to the engagement with someone who is suffering from a disorder. I don't have an issue with it, but I know, you know, people like Chris do. It's, I think, and also, you know, we're not sort of, and, you know, my use of the term mad, for example, you know, people might go, oh, you shouldn't say mad or madness, but, you know, it communicates and it's okay. And there can be sort of some too much political correctness that obscures our interactions. So I think disorders of self is fine. It's someone who's suffering within their sense of self, and their experience is disordered, their experience of the world is disordered. Yeah. Though that's not to say that, you know, that other aspects of their experience are completely fine. So this is also another aspect of this system, is that it can recognize that someone can be very together and, you know, positive and functional in their lives, but at the same time still have this other aspect that doesn't work so well in and sort of interrupts their positive engagement with themselves and others.
So it sounds like you're suggesting sort of it doesn't necessarily need to be all encompassing. You know, it's not that their fundamental entity is sort of is disordered. It's just that some aspect of their self isn't functioning optimally.
Yeah.
Sure. Gawain has asked, and it's an interesting question, whether you've tried playing back. So I guess you talked about recording the interview as part of the process. Have you tried actually playing back elements of the interview to kind of to either, I don't know, give the individual with whom you're interviewing an opportunity either to clarify points or kind of refine the process further?
Well, I haven't actually used this interview in a clinical situation. Sean and I have been drawing on secondary material. Rosa has the clinical background to engage with people in that context. And so our current project is looking at some of her primary data on people suffering from psychosis. So that should be interesting, but it's in the pipeline. It's yet to come. But that's an interesting idea. That's a really interesting idea. And just see, you know, what they would, how they would reflect on that, you know, as a retrospective kind of view on themselves. Yeah, interesting.
I guess in terms of like different professional stakeholders, so psychiatrists, psychologists, people in lived experience movements, what like to the extent that you've kind of workshopped this idea, presented it around, what has been the reception? How have different stakeholders kind of responded to these kinds of ideas?
I think some of them have been outraged. How dare you, as a philosopher, even enter the space? But we're allowed to. Philosophers are allowed everywhere because we're looking at have you got your thinking straight? Have you sort of got your design correct? And I think I've been at a number of things where I've heard people working in the human sciences present stuff, and I go, not a huge amount, but just occasionally there have been things I think that's not very well thought through. They should have front loaded some phenomenology for their project to just tease out some of the design issues. So there has been pushback, definitely, and others are very encouraging. Of course, the whole team that's involved in phenomenological psychiatry are very interested in this, and they're very interested that there's been take up from all sorts of people, psychologists, contemplative practitioners, as well as neuroscientists. So, and so it's been really, really interesting to see what's happening in that space.
Do you see any division among or any kind of separation among the types of peoples that are more open? I'm just imagining, for example, that people who operate more in the kind of psychoanalytic or psychodynamic space might be much more comfortable with this idea because the way in which you approach the treatment kind of is much more open-ended, and the questions are much broader, and even the interventions, potentially less structured. Whereas those individuals who do more cognitive behavioral or short-term approaches, there's often the sense of, well, I have very limited time, and so I need to get in, figure out what's going wrong, and kind of get something done quickly. So have you observed kind of a division between that more support coming from the analytic and dynamic community, or do you feel like it's kind of people of all walks of life and professions are kind of are equally enraged and inspired?
No, I think you're right, because I actually did notice that because it's a minimally structured interview, it has much more in common with, say, the psychoanalytic approach. For them to talk, but it's got some intervention. It's not entirely passive on the part of the analyst. But there are some commonalities there for sure. Well, we'll just have to try it out and see how it goes, and see if they start losing patience. And let's see.
So there's a question around the idea sort of that you're using kind of like body-based mindfulness techniques. And I guess that there's this question, I guess that the question really is around sort of that for some people, I guess certain bodily anchors are particularly problematic. So for some people, for various reasons, focusing on the breath is difficult. So say someone with anxiety. So do you see ways within this particular approach to use alternative anchors or even alternative approaches to kind of help create or facilitate something like mindfulness or presence, as you described it?
Okay. So yeah, I suppose between, you could use your voice or something as an anchor too. Just listen to my voice or whatever. But it's the idea is that they are there in the moment. And one of the things that Chris and I have been sort of working on the side, we haven't quite finished that yet, but we're getting there, is that whole idea of the importance of presence, and that presence can be very problematic for people suffering from anomalous experiences. So that's a challenge, but it's also an interesting one, a very interesting one that sorted out properly.
Gawain has asked about the relationship between the idea of the disorders of self and the ideas of social disorder. So talking about individual dysfunction. So he's just asking, I guess, if you could talk about the distinction between disorders of the self, so how people, I guess, the self might be disordered versus, something going on more broadly. Then he mentioned sort of this idea of a communitarian culture and how there may be problems sort of going on environmentally that influence the self-related processes. Do you have thoughts about that?
Yeah, absolutely. And that's one of the key things for the pattern theory of self, is that it takes into account those external factors, the cultural, the social, the political, and how they impact on an individual's sense of self. So in the talk, I did mention, some of the work done by feminist philosophers around that particular issue. So Iris Marion Young, Throwing Like a Girl, read it, please. That'll sort of clarify things for you. And also the work by Harvey Carell in terms of illness and being embedded within a hospital system, but also a wider society that has problems with people who are suffering from various medical issues, let alone psychiatric issues. So yeah, definitely that's part of it. They're not separate.
What do you think are the kind of the next steps from your perspective? You talk about kind of getting people to maybe try it and see how it works. But are there particular barriers to your mind that sort of kind of need to be overcome to explore these ideas further?
Well, I think there is a general willingness to give it a go. And Rosa particularly has been working on this over in the UK, and we're hoping to get a project off the ground that is across various institutions that will provide a basis for applying it and doing various studies, preliminary studies, and also trials to see how it works. So it's happening. It is happening.
Great. I think we might leave it there then, unless you have time for a few more, or.
I think that sounds good, unless there's some urgent question there that you can see that.
No, I think that's great. So thank you so much for your time and your thought-provoking presentation. And thanks to the audience for joining us. Please do subscribe to our newsletter to stay informed about events like this and other events upcoming in the series hosted by our center. And we look forward to seeing all of you next time.
Great. Thanks a lot, Nicholas. Bye.